Pen, marker, what do you need? Knife? Sticker. I don't have a knife.
I've got plenty of knives. You want a knife?
I leave them at home.
Sticky note.
Sticky note. Sticky note. Sticky note.
I have it for Dr. Ping. I can't. Okay, Johnson, find a word. It's a verb. It's a verb. Where's going?
They're going so far. You know, we're at that point in the semester where it started, but I don't have anything to grade yet, and I'm just waiting for it to start. This is very odd to me. AVH 5, 102.
I just want to tell you about my sister, I don't want to think wrong way. I don't like my sister. I still love my sister that I always did. I guess, you know, she done help me. She done good thing to me. Time I know I love her. I still want to think about.
Keepers, under some of the resources that are here, so we have. Right there. Mm-hmm. Mm-hmm.
All righty, everybody. Welcome. My name is Ben Amick, and I'm the co-originator of this series with Liz Gates. And so thank you all for showing up to the first public health seminar series for 2021. Today, we're fortunate to have Dr. Jeannette Lee presenting. Jeannette is a professor of biostatistics who joined UAMS in 2008. She received her PhD in biostat from the Johns Hopkins School of Hygiene and Public Health, now the Bloomberg School of Public Health. She is currently one of the PIs of the Data Coordinating and Operations Center for the IDEA States Pediatric Clinical Trials Network and director of the Statistical Center for the AIDS Malignancy Consortium. If you look over Jeanette's career, she has led many NIH coordinating centers, which is duly impressive to me. She is currently a member of the FDA Cellular, Tissue, and Gene Therapy Advisory Committee and serves as a temporary voting member of the FDA Vaccine and Related Biological Products Advisory Committee. Please mute yourself if you're not muted. If you have questions that are urgent, put them in chat and I'll call them to Dr. Lee's attention. Otherwise, we will have time at the end for questions. So please join me in welcoming Professor Lee.
So thank you, Dr. Amick. I'm very happy to be here and share with you some of the things that have been going on with the advisory committee for the COVID-19 vaccine. I have no disclosures. And this is a brief outline of what I'll cover today. The first will be a little bit of an introduction, and then some information on the guidance that the FDA provided to industry on the development and licensure of the vaccines to prevent COVID-19 and regarding how the clinical trials should be conducted and what requirements were there. I'll also talk briefly about the characteristics of the two COVID-19 vaccines, that both of which have submitted a request for an emergency use authorization, and then we'll have time for questions. You know, I tried to start this early last month, and then I realized, as all of you know, the pandemic has been a moving target. Unfortunately, it is increasing regularly. So I waited till yesterday to finally download this picture that you can see that from March, it's been a steady uphill climb. We've had a couple of plateaus, but we're certainly in the worst place we've been in the pandemic. As you can see, this is from yesterday's New York Times. Our caseload in the last 14 days has gone up by 38%, our deaths by almost 50%, and hospitalizations by 11%. So this is clearly not a good place to be. Based on the COPH report from last month, you can see the projection of cases here in Arkansas. And as you can see, it is also a steadily rising curve. I want to give you a little background on, for those of you who may not be familiar with how we measure vaccine efficacy, since this is a key component in evaluating a vaccine, just the definition of what it typically is. And so you typically will have a control and a vaccine group. And what you'll see is an incidence of the disease on control, and in some cases a placebo agent, as opposed to incidence on the vaccine. And the vaccine efficacy is really taken as the amount of the disease that is controlled by the vaccine divided by the control. So it's a proportion of disease prevented by vaccine. So just to give you an idea of what vaccine efficacy looks like, I think you're all familiar with the seasonal flu vaccines. And as you can see, over the last several years, we've ranged from 21% to 60%, back down to 29%. But our vaccine efficacy for the influenza vaccine has not peaked really past 60%. And in fact, we've been doing pretty well in some years of getting close to 50%. So that's just a little bit of a backdrop for considering the vaccine for the COVID-19. Now, there are two types of FDA approvals, and this is from the Center for Biologics Evaluation and Research, otherwise known as CBER. What is called a BLA, or a Biological License Application Approval, is a full approval for a vaccine, or actually it's also can be used for therapeutics and diagnostics. An emergency use authorization allows for the use of an unapproved product, that is one that has not been through the whole full approval, but it can be used, and if needed, for serious disease. And also, if there's not an adequate, approved, or available alternative, And to be approved means having a full approval, not another emergency use authorization. And at this point, there are no fully approved vaccines for COVID-19. Just as a reminder, some of you may recall that over the summer, hydrochloroquine was in fact approved for emergency use for COVID-19. And that authorization was later that summer revoked after a couple of well-controlled clinical trials demonstrated that hydrochloroquine did not have an effect on the management of COVID-19. So in June of this year, or I'm sorry, June of last year, FDA released their development and licensure of vaccine. They had the guidance to industry on what they should do, what would be considered approval, what they would consider for full approval. And you may recall there was a bit of a political tussle, but this is what was released in June to industry. They first pointed out that early phase studies, which are usually phase 1 and 2 and are primarily done for dose finding or for safety, and they typically expose a modest number of participants, should evaluate preliminary clinical safety and immunogenicity studies. They also wanted the late phase trials, typically phase 3s, to demonstrate vaccine efficacy. So the early phase is really more of a safety measure. They also had some constraints or recommendations for the populations to be used in each of these studies. So in the initial studies of early phase, phase 1s, the plan was to enroll healthy adult participants at low risk of severe COVID-19. They did allow older adult participants over 55 years of age to be enrolled in early phase, as long as they did not have medical comorbidities associated with an increased risk of severe COVID. Preliminary safety data in younger patients should be available prior to enrolling this older age group. So they wanted information in the under 55-year-old participants before they enrolled the older ones. They also suggested that early phase studies should exclude participants at high risk for getting COVID, and that included, at that point, healthcare workers in the early phases of the studies. For the late phase studies, they did want, you could include individuals with a prior infection, but not those with acute COVID-19 or any other acute illness. They also encourage the inclusion of diverse populations, including those disproportionately affected by COVID, specifically those racial and ethnic minorities that have sort of borne the brunt of the hospitalizations and severe COVID. There was also a desire of adequate representation of elderly individuals and those with medical comorbidities. This is in the late phases. They also encourage the vaccine developers to consider developmental programs to support the inclusion of pregnant women, women of childbearing potential, not actively avoiding pregnancy, and also to plan for pediatric assessments of safety and effectiveness. They also had recommendations for their efficacy endpoints, and that included that the primary efficacy endpoint was recommended to be virologically confirmed SARS-CoV-2 infection with one or more of the following symptoms, and you can see these are the common symptoms that have been described associated with SARS-CoV-2, the cough, the respiratory ailments, the headache and fatigue and so forth, including the loss of taste and smell and so forth. So these were the symptoms that really had to be accompany the actual diagnosis. They also require in this guidance document that a secondary endpoint be severe COVID-19, defined not only as a virologically confirmed SARS-CoV-2, but with any of the following, such as clinical signs indicative of severe systemic illness, respiratory failure, evidence of shock, significant renal, hepatic, or neurologic dysfunction, admission to ICU, or death. And so that was the definition that they had for severe COVID-19. Now, one of the things that they wanted in terms of vaccine efficacy was that the target of vaccine efficacy should be at least 30%, And the lower bound of an alpha-adjusted confidence interval around that primary efficacy endpoint should be at least 30%. So 50% was the target, and the confidence interval had to be, lower bound had to be at least 30%. Now, in terms of safety considerations, for full approval, they required that there be solicited local and systemic adverse events for at least 7 days following each study vaccination, that unsolicited adverse events in all participants should be observed for 21 to 28 days following each vaccination, and that serious and other medically attended adverse events be followed for at least 6 months after the completion of all study vaccines. So the intent, at least for the full approval, was a follow-up at least 6 months for safety purposes. Now, later in the year, October, and this was the first meeting I attended, which was October 22nd of last year, the FDA provided additional guidance to industry on what they would be looking for the emergency use authorization for COVID-19 vaccines. Now, there are 4 specific criteria. One is, and this is certainly not debatable, that SARS-CoV-2 can cause serious or life-threatening disease or conditions. So clearly that requirement was met, that the prevention of this was very, very important. The second one really is how the FDA asked the advisory committee to judge the vaccine, which is based on the totality of scientific evidence available at the time. It is reasonable to believe that the product may be effective in preventing, diagnosing, or treating this serious or life-threatening condition caused by SARS-CoV-2. The third is that the known and potential benefits of the product outweigh the known and potential risks of the product. And the last is that there is no adequate, approved, and available alternative to the product for diagnosing, preventing, or treating the disease or condition. Now, at the current time, there isn't. Getting an emergency use authorization does not mean that there is an approved and available alternative. And in response to a question asked about if there were one vaccine approved with a full approval, would that prevent emergency use authorizations for other COVID-19 vaccines? The answer was no, because in fact, there may be a need for different types. As you know, that some of them have different mechanisms of action and different availability, and certainly storage conditions have something. So there is a possibility for having multiple emergency use authorizations, even if at least one of the vaccines has a full approval, which has not occurred at this point. Now, the requirements for an emergency use authorization was that the data from the phase 3 studies would include a medium follow-up duration of at least 2 months. And I think that's critical to recognize that the emergency use requires a median of 2 months, meaning at least half of the participants have to have it observed for more than 2 months. That also means half of the participants could have been observed for less than 2 months after the full vaccination. So that's an important thing to keep in mind, recognizing that for full authorization, you would need a follow-up of about 6 months. The risk-benefit profile would include, obviously, the adverse event, the cases of COVID-19 as described for the efficacy endpoint, and the cases of severe COVID-19. The efficacy requirements were the same as for the biological license approval. That is a 50% vaccine efficacy with a lower bound of the confidence interval of at least 30%. So the other factor that they brought up, and I will point out it caused some discussion in October, it is because these were placebo-controlled trials, the FDA's expectation was that following the submission of an emergency use authorization request and issuance of the same, that the sponsor would continue to collect placebo-controlled data in any ongoing trial for as long as possible, and would obviously as well work towards submission of a full approval. So the question was, how long could you keep people on placebo, especially if you know what the efficacy is of the vaccine? And so this was a statement in that guidance document that there was a desire to keep people on placebo as long as possible. So, and before I get to that, I would just point out all of the October, December, and 10th and 17th meetings were recorded by FDA, and there are multiple different designs that allow you to keep placebo-controlled individuals on as long as possible. There was probably, I would say, about a 15 to 20-minute presentation on December 10th and 17th given by Dr. Stephen Goodman at Stanford, who's an epidemiologist, on these placebo-controlled options. And for those of you who are interested, I would certainly encourage you to find those recordings on the FDA website to look at that. So let me go through what transpired as we looked at these various agents. Now, there were two meetings and they were only a week apart, and I have to say I'll have to give the FDA credit for being able to host these just a week apart with all the material they had to put together. It was really quite a feat. Now, the questions that we were asked to answer for both of meetings was, how should the sponsor handle the placebo participants if the vaccine receives an EUA? That was one question we were asked to consider, and it's a non-voting question. It was one that the advisory committee was asked to discuss. And then the second one was really the voting question. Based on the totality of scientific evidence available, do the benefits of the vaccine outweigh the risks for use in individuals X number of years of age and older? And I put the X in because there were different requests for the two vaccines. So on December 10th, Pfizer BioNTech presented its information. I find it sort of interesting. I actually did get a notice from the FDA, but some of this stuff apparently gets broadcast before the FDA releases it. The FDA is required to provide 15-day notification to the public of any of these meetings it has, especially regarding these vaccines. So the Pfizer vaccine, as some of you may already know, and this is a picture from the protocol for the phase 3, is that it is administered 21 days apart. And then you can see the plans that they had for following people up. There was a plan to follow people up for the serious adverse event. There is a plan also to follow people for 2 years post the second dose for other related serious adverse events, etc. Now, the race and ethnicity distribution here, as you can see, it was predominantly non-Hispanic. You will see, although there was reasonable representation of minorities, approximately 25%, 75% were white. We had about 12% African Americans, and you can see the rest of the distribution of the race ethnicity groups here. You can see the age was kind of skewed. I would say in the Pfizer trial, it was 16 to over 75. As you can see, you can barely see the 16 to 17-year-olds. There were about 30,000 individuals in this trial, and there were really only about 116 to 16 to 17-year-olds. The majority of the individuals were 18 to 64 years old, and then we had a little bit less than 20% that were 65 to 74, and a relatively modest number who were 75 years and older. The comorbidities were actually quite substantial. You notice in the bottom two, there were 35% that were obese and about 35% who were overweight. So essentially 70% that were overweight or obese. Hypertension was probably the next most common comorbidity at almost 25%. And then we had about 8% with diabetes. Most of those were uncomplicated, and a more modest number of individuals who had chronic pulmonary disease. What you will see here, and this is from the New England Journal article in which this was reported, even though you have something like 30,000 individuals, the determination of the vaccine efficacy is really based on the number of cases that is observed in the time period. So as you can see, even though we have about 36,000 participants, the actual determination of the vaccine efficacy is based, as you can see, on approximately 170 cases. And the question is how they sort out between the vaccine, which is, this one's called BNT162b2, and placebo. And as you can see, it's sort of a 20-fold difference in that there were only eight cases in the vaccine arm as opposed to 162 in the placebo arm, giving you a vaccine efficacy of 95%. And they use the Bayesian credible intervals, which are very similar to confidence intervals, but that credible interval went from 90% to 98%. Now, the only difference that you will see between line 1 and line 2 is that these were all in participants without any evidence of infection. Another secondary endpoint that they had was to look at people who might have had evidence of infection at the time they were enrolled. And as you can see, the numbers go up slightly. We're almost at about 40,000. And yet there were still the same disparity in the number of cases and its distribution between the vaccine and the placebo group. So it's really a very impressive difference. Now, one thing they also did here is that they split these out by the various age groups and were able to show, in fact, that you had a 95% efficacy overall, 95% for your 16 to 55-year-old participants, and 94% in the 55 years and older. And the reason for the larger a confidence interval in the older age group really is completely related to the number of participants and the number of cases. But that pretty much demonstrated that there really wasn't any disparity in terms of the efficacy, vaccine efficacy based on age. Now, as you can see, this is the effect of the vaccine against COVID-19 after the first dose. And so I don't know if you can see my cursor moving here. This is the time of the first dose, and at 21 days is the time of the second dose. And there seemed to be a little bit of a bump later on. As you can see in the placebo group, the cases sort of, it was almost a linear curve going up a long time. So you can see where that is. If you look down here, you will see the efficacy after the first dose was about 82%. Between dose 1 and dose 2, I don't know what to make of that, 52%. And then this is dose 2 to 7 days after dose 2 is 91%. And then after 7 days, and that was where they'd had their benchmark really, is well, there's 7 days after the second dose. Now, what you can see here is, and I know this is an extremely busy slide, but this sort of points out for you the safety measures. If you look all the way to the left, the 3 measures there are pain at the injection site, which, as you can see, occurred in almost most people, redness and swelling. The 4 tiers you'll see is the top line is events in the 16 to 55-year-old group after dose 1, and the same age group after dose 2. And then the bottom 2 lines show those over 55 years of age after dose 1, and the bottom line is those over 55 years of age after dose 2. You will note with the color coding they have here, the green is mild, the blue is moderate, and then there's orange and red for severe and grade 4, which is often considered life-threatening. And as you can see, in the left-hand, local events to the left is pretty rare. If you look on the right-hand part of this, which are the systemic events, and going left to right, you will see it's fatigue, it's fever, fatigue, headache, chills, vomiting, diarrhea, muscle pain, joint pain.
I cannot believe, Tisa, that I was feeling that bad.
use of antipyretic medication. So as you can see, many of these things have occurred in more than 50% of individuals, but the fact that these are mild and moderate suggests that they're relatively transient. They last for a day or two and don't really have, you know, severe sequelae for most people. So this, from the standpoint of what you might expect from vaccine, is pretty common. I do believe for the Pfizer group, they did not include people that had a history of anaphylaxis. And as some of you may recall, when it was first rolled out in Great Britain, there were two healthcare workers who did have an anaphylactic reaction. Interestingly enough, both of them clearly had a history, since both of them also carried EpiPens with them. So they had that. And there was one, I think, in Moderna that occurred up in the Boston area. So one thing to note here is that there were some populations that were actually not, in fact, included. The children under the age of 12 were not included. I didn't show the slides for 12 to 15-year-olds. They were not included in the vaccine efficacy. Some of you may recall that they were enrolled fairly late in the process. They were enrolled in October, and this presentation, the data cut, was in November, which meant that they didn't really meet the median 2-month follow-up for efficacy. I will say the reports that were provided to us did include safety data of them, and again, the 12 to 15-year-olds had similar reactions as we were able to see in the adult populations. This study did not include pregnant women, and it also, and this was some discussion, did not include immunocompromised individuals as well. Their plans for the placebo participants were to vaccinate placebo participants at the time they would be eligible for vaccination in their location. And I would point out this study was done in the US and I think also in Argentina. I don't know if they're rethinking that, because as we've seen in the news, when you're eligible was really kind of a moving target depending on where you are. But that was the plan that was presented by the Pfizer group. Now, the emergency use authorization for Pfizer came up to a vote. We had 17 yes, 2 no's, and 1 abstentions. And I think the question I've been asked most commonly is why were there no's? And I would say one individual was concerned about the inclusion of 16 to 17-year-olds. The data for that group was not presented separately. They were sort of rolled in with the 18 to 55-year-olds as well. So that was a concern. There was also an individual who was concerned about the fact that pregnant women were not included, but that the authorization would include those. I will also say that the underlying reason, and there was 1 abstention, I will also say that the underlying concern and the reason I think for some of this was there was a complete frustration on the part of the committee that the meeting day had been so packed that many people, including those who had the concerns about the pregnant women and the 16 to 17-year-olds, had not had a chance to ask their questions and get full answers. And that also became apparent in the week between the 10th and the 17th. And as a result, there was a lot more time for questions and answers from the committee in the following week. So a lot of the no's were that people felt they didn't get adequate information to address these particular groups. As some of you know, the FDA approved that emergency use authorization on December 11th. Now, one thing you should know is that the Moderna vaccine, which I'm going to talk about next, was not provided, was scheduled for a week later, but in fact, we were not provided with any information about the Moderna vaccine until after the 10th, recognizing that FDA did not wish for us to be biased for or against the Pfizer vaccine based on what we had from Moderna, which means you got a lot of stuff to do in a week. So the Moderna vaccine was reviewed on December 17th, which was just merely a week later. And the vaccine has a similar sort of two-dose schedule, which is a 28-day interval between the doses. Now, their race and ethnicity distribution was somewhat similar. I think there were more Hispanic individuals in this population. And again, the distribution by race was probably not that dissimilar. I think there was one part that indicated about 35% of their population was in fact of communities of color. I would also say one thing that they did note here, which was not clear from the Pfizer submission, was that approximately 25% of the population in this study was in fact healthcare workers. The age distribution here, they split it up a little bit differently. They started at age 18. They kind of stratified the group into 18 to 64 without any comorbidities or risk factors, 18 to 64 with risk factors, a smaller group, and then 65 and older. Their comorbidities were quite a bit less. I'm really not sure why that is. They did not classify obesity as one of the risk factors, but severe obesity. I would point out that when you look at the demographics of this group, the average BMI for the population is 29, and some of you who are familiar with the BMI measures know that 30 and above is actually considered obese. So we're certainly not, this is not a slender group here or in the Pfizer study. Diabetes was at about 10%, chronic lung disease a little less than 5%, and the same for significant cardiac disease here. Now they actually, their vaccine efficacy came in at about 94%, and as you will see on the left-hand side, once again, we have about 28,000 participants, but the decision again is made on less than 200 of the infections. In this particular case, there were about 196 infections, and as you can see, predominantly in the placebo group, not in the mRNA group. As you can see through the rest of the forest plot, all the point estimates seem to be pretty much there's a little bit of a less of an efficacy in the 65 and older. It's at 86%, but again, that meets the threshold of 50% for an EUA and a lower bound greater than 30%. But it's a pretty consistent across these age, race and ethnic groups and risk factors and gender, a pretty high vaccine efficacy rate. Now this curve kind of shows you once again the days after the randomization, the days after dose, and as you can see, the infections in blue are very low in the vaccine group, and in the placebo group are really quite high. As you can see here with the systemic events, and I know this is a little bit difficult to read, the local events are above and systemic events are below, but left to right it's placebo dose 1, placebo dose 2, followed by vaccine dose 1 and vaccine dose 2. Most of the local reactions, once again, are grades 1 and 2, and the same is actually true for the systemic adverse events, although there seem to be, and of course the scales are not exactly the same, a little bit more in the Moderna for the serious dose 2 headaches and fatigue as well, but not really markedly different. The profile here is very similar to one that we've seen in the Pfizer vaccine. Now, populations not included here include children under the age of 18, pregnant women, and immunocompromised individuals. So that part is the same. And their plans for the placebo participants are to vaccinate placebo participants immediately at the time of EUA approval. Some of the motivation for this was that Moderna had a clinical trial supply of the vaccine they could use for this purpose, but they could not roll out to the general public. And so that was their plan, was just to use it for that purpose. Before I get into the vote, I will point out a couple of other things that the Moderna group did tell us while we were in the meeting. One was that, as you may recall, if we go back up here, and you'll note we had about 196 cases. I would point out that this data was closed at the end of November, like November 25th. What they did point out to us is that in the period from November 25th to when we were meeting on December 17th, they had received reports of a close to 400 COVID cases among their study trial participants. Moderna has a case adjudication committee, and it is in the process of culling through those, making sure they meet the definition. So exactly what they will have if they go in for full will have obviously more cases than what we were seeing here based on the data cut from the end of November. The other thing that they pointed out on one of the questions that came up was why it is that they chose the 100 microgram dose. They had two others that were in phase 1, 25 and 50. And the answer that they gave us was that, in fact, at the time they had to decide to start the phase 3 trial, they had to pick a dose. The phase 1 trials were not concluded. And so in the absence of anything that suggested a major enhanced safety risk with the highest dose they had, that's what they went with. That sort of means you don't know. It might work at 50, it might work at 25. I mean, they took their best shot. I think I probably would have done the same, but there's a lot we still don't know. So I think those are sort of some interesting points that came up in the Q&A. Now, in this particular case, we did actually have a full approval. Virtually everybody voted for it. It was a unanimous approval, and the FDA approved the emergency use authorization on December 19th. So I think that that is, this is sort of record time. I know they're all out in the field. And I think with that, I'll be happy to entertain any questions. Thank you.
Thank you, Dr. Lee. That was wonderful. And I love the picture.
That's when we could travel. We went to Antarctica 2 years ago.
Oh, that's cool.
Yeah.
Dr. Bates, are you on this call? I thought I saw
Yes,
Joe
I am.
Bates. Do you have any questions for Dr. Lee?
I do. Dr. Lee, first of all, I did really enjoyed your presentation. It was very helpful for me. In the Pfizer product, there was such a small number of people that were 75 and over, and they were grouped together with those that were much younger.
Right.
Did they give you any data just on the total numbers in the 75 group and what happened to them?
No, they really didn't. They got rolled together. They were so small, and some of, you know, sometimes we had small numbers. There was another group, we had a small number, and it looked like it was 100%. And that's because there was no COVID cases sort of in the vaccine group. So they did not provide separate information for 75 and up. I'm hoping when they go in for their full approval, and Pfizer did tell us they were targeting the second quarter of this year, that we will have more information there.
I was wondering why they had so few 75 and over. That's really the most
vulnerable group. Yes,
yeah.
Yes.
Very disappointing.
Yeah, it is. I don't really know the details of the recruiting mechanisms and so forth. So I'm not really sure why that is. But you are absolutely right. That is probably the most vulnerable. Actually, that was discussed within the advisory committee that, you know, we were recommending all of these things, but we didn't have information on individuals in long-term care facilities and all that. That we were sort of giving a blanket approval, et cetera. Although we did recognize a lot of these groups were not fully studied.
Thank you.
Dean Williams, do you have any questions?
No, I thought this was an excellent presentation, and I want to congratulate you on it. This is the most understandable presentation I've heard on this subject. So I really think it's very, very good. And thank you so much.
I would note that there are, thank you very much. I do know that, that the one thing I will comment on is that the two vaccines we've seen so far require these two doses given 21 or 28 days apart. I will point out the Janssen J&J vaccine, which I think uses more standard sort of vaccine technology, is one that would be given in one dose. And I think that as things kind of sort out, that certainly might have greater uptake just because of the convenience and how hard it is, we know, to get people to come back in for the second dose.
Dr. James, any questions?
Can I ask a question?
Sure.
I am Victor.
Sure.
Congratulations, I enjoyed your presentation. I have a question about what considerations have you heard, review, or what are your views about the some evidence that, you know, I'm not convinced, but there are people who claim that the antibody levels for the SARS-CoV-2 virus infection decline considerably to the point to which they are not detectable. There is a piece on the MMWR recently and adds to previous reports going back to the Hubei pandemic, in the pandemic in Hubei. So what do you make of that in relation to the effectiveness of the vaccine?
You know, I haven't really looked at those reports. I don't know how to interpret that, honestly. I appreciate you bringing that up, but I don't really know that I have much information to contribute there.
Okay. Dr. James, before we move on, let me give you the floor for a minute.
Yeah, Jeannette, thank you. That was a great presentation. I think I missed what you said about special populations or groups with underlying disease and kind of what the next steps you think we will see in those groups, and then also in pediatric vaccination programs, how far down in the age group do you think they will go on that?
So I can tell you that our colleague, Jessica Snowden, has been approached by Moderna about doing a phase 1 trial in children. I think she says 16 to 12 years old to start, and then going down, they're going to start with a phase 1. So that's the only thing. And I have heard through various sources that Janssen is planning on launching a study of pregnant women. I don't know exactly when that is, but I have heard that through somebody affiliated with NIAID. So those things are in the offing. The immunocompromised population, I haven't heard much about, but again, it's one there's obviously a lot of concern about because it's a high-risk population, but also has high risk for other sorts of things. So I have not heard much about that, but I suspect that some of those things are coming down the pike.
Thank you.
I have another question, Dr. Lee.
Sure.
I think it was the Pfizer product that the first dose protected about efficacy was about 80% that you told us.
Right.
And that's wonderful. And I'm wondering if you would want to comment about, since we're holding back so much vaccine for the second dose, we're having, in Arkansas, we're having 40 deaths a day.
You're right.
And we're going, slow as molasses in getting it done. And we have to hold back the dose for the second dose. Is this the best way to control this pandemic?
I think there's a lot of stuff we don't know. I think the group we had with 80% efficacy with one dose was not probably an unbiased sample of the entire group. So the majority of the people did get 2 doses. But you're absolutely right. because one of the things we talked about, Moderna, could you do a non-inferiority, say you need just one dose, or would you do just as well with that, or not much worse? You know, and I don't know that we know the answer to that. My perception in talking in both of the meetings is that both groups gave it their best shot, which is to have 2 doses, et cetera, at an interval, et cetera, at the highest dose they had. I don't know that it's possible it would do just as well as 1 dose. We don't really know that. But you know, I know it's very controversial as to whether you should just give 1 dose and not worry about doing the 2nd dose, because the efficacy we're seeing is purely with the 2 doses, and the group that got 1 dose, I think, is a very small group, and perhaps a skewed group as well.
Thank you.
I have questions in the chat, but I wanted to make sure there was nobody else who wanted to ask a question.
I don't have a question, but I do have an announcement that's germane to this presentation. For those of you who have not read your email yet, UAMS has received 5,000 doses from the health department of vaccine. And so vaccination at UAMS is now open to all employees.
Good. Okay, so there's a question, is there any data or support information on whether or not vaccinated persons could carry the virus to someone not vaccinated?
So actually the Moderna product and their trial was looking at asymptomatic spread of those who were vaccinated. At the time that they presented to us, that data was not yet mature. And so what the advice that is being given to everyone who is vaccinated is to continue to use your masks, because it is unknown whether you could transmit to others, even if you yourself are at low risk of getting infected. So we don't know the answer. It is certainly being studied right now.
Thank you. This is a very technical question, so Terry Harville may need to correct me. Were anti-ACE2 autoantibodies checked? Were anti-AT1R antibodies checked?
I don't know. I'd have to go back to look at the protocol. It wasn't presented, but that doesn't mean that that wasn't looked at.
Okay. Is there any indicators? Thanks for taking these questions. I feel like I'm on a talk show now. Is there any indication as to whether the 400 cases in the adjusted Moderna findings post-November are in favor of higher efficacy or lower efficacy?
We don't have that information now. They were in the process of having those go through the adjudication process. So they didn't have any data to present other than to let us know that they were in the process of working through those.
Then one final question I have is the incidence of reactions for individuals with severe allergies the same as what they saw in the clinical trials, or were there individuals excluded from the studies?
I think the Pfizer group excluded those individuals, and they didn't really see that in the Moderna one. So it appears to happen really, but you know, even out of 30 or 40,000 individuals, once you start vaccinating millions, as we know, you start seeing certain reactions that you would not have seen in a smaller group of participants.
Any other questions for Professor Lee? Well, I'd like to thank you on behalf of the College of Public Health and just give a shout out. I think we're very lucky to have a member of our faculty on this committee. It's an important committee. It's a prestigious committee, and it's not like the world is sitting on this committee. This is a very special group. So congratulations and thank you.
Well, thank you very much. And I'm very pleased to present, and I'll certainly be happy to give updates as things evolve. Thank you.
Oh, thank you. Have a safe day, everybody.
Okay, thanks.